Hi, everybody. Oh, the window's open, so there's going to be background noise. Um, I'm going to do the 5th episode, and my dog's running around, of Carpools and Cannulas with Dr. Greer, so she should be joining us in a hot second. Tonight we're going to talk about breast lift, so to lift or not to lift, and hopefully my dog doesn't have an opinion about it. So as soon as Jen Greer joins, we will get started. So it's a common question. I guess while we're waiting for her, Dr. Greer, to join, I can just talk about why my face looks a little busted. I just had, there she is, radio frequency microneedling done literally half an hour ago. And so this is for reals. All right, let me just have her join us. All right. Hopefully she's, oh, there you are.
Hi. You look
Hi.
glowy. Okay, do you ever have that moment where you're like, crap, am I hosting? Who's hosting?
Yeah.
And I'm like looking at our texts.
I had like 2 minutes and then I was like, oh, let me check some messages. And then I'm like, oh my God, I got to get on. So
Yeah.
yeah.
You look glowy though. So you had radio frequency microneedling?
Yeah. So we were just doing kind of like a reboot since we've had the machine for a while and kind of retrain, just an update. So we were treating the 2 doctors, myself and Dr. Taylor, who office shares with me, treating each other and just going over what we've learned so far in doing treatments. But yeah, I was red right after the treatment, but they have this amazing mask that you put on afterwards that I drove home with. And it does really take the red out. So I'm kind of excited. Yeah. My face is mostly not numb, so I can talk.
That's good. Do you guys use topical for that?
Mm-hmm. So yeah, we do numb with topical numbing cream for about 30 minutes. And then it's very, like most things, adjustable so that if someone has trouble tolerating it, then we can adjust accordingly. And then we have a Zimmer. You can cool off with that. But yeah, most people do well with topical. Do you do microneedling in your office?
We don't have that. We have the Halo on the Cyton, so we do that.
Oh, yeah.
I do love my Cyton.
Yes. That's why your skin always looks so good. So it is,
really... I have not had a Halo peel in 2 years, and I haven't had a BBL in like a year. It's terrible. I just never have time. You know how that is. You're like, well, I'm busy.
Yeah, no, we were really excited. Mahmoud just joined us. He's the rep for Cartessa. We had done a training, then we've been doing a bunch of treatments. And then he was like, you guys need to do another treatment on yourself. I'm like, yeah, we keep talking about it, but we never carve out the time. And he's like, well, I'm going to come and be there. So then we had to like really block off the time to do it. So
nice.
Yeah,
that's good.
Yeah, absolutely. So I thought, so this evening we thought we'd talk about breast lifts, right? Because it's a common question that comes up for sure.
It is. And I think last time we finished, we had mentioned we were going to talk a little bit about implant removal. So I think talking too about when you'll need a lift and when you won't is going to be helpful for people.
Yes. So yeah, to my cheesy tagline was to lift or not to lift, but I think it's a common question, right?
Yes. Well, and often too, when people call the office, they're not sure if they want a lift or an aug. They're like, I don't know. What's the difference?
Right, absolutely. So why don't you break down breastosis, which is a fancy way of saying
I'm reading Eric's comments.
I know.
Okay, so to describe breastosis, I'm going to share a fun story from my 6-year-old. He hates when I share this because he says I can't say breasts on Instagram. So he comes in, I'm changing into my jammies. He's like, Mom, breasts look like penises because we use all the words in our house. And I'm like, I am not following how that similarity. He's like, well, they both point down. I was like, oh, no. Out of our room. Yeah, that was it. So, it was awesome. I get a lot of mileage out of that story, though. So that's breastosis. There's different degrees of it. So when you have pseudotosis, the nipple is above the inframammary crease, which is that fold under the breast, but some of the tissue hangs down. If you've got grade 2 tosis, the nipple is at the level of the crease. And if you have grade 3, it's you got the downward vector.
You have the penis breast? Is that what we're going to call it? Downward?
No. Downward vector.
Okay, all right.
Or as my patients say, if you like roll them up and tuck them into your bra.
Grade 3 tosis. Right.
Yeah, that would be grade 3 tosis.
So, right, it's all about the nipple position relative to the rest of the breast, essentially. And so I feel like we're able to look at a breast and say, yeah, you know, we can either add or subtract volume, right? But that generally doesn't change the nipple position. It sort of, if you add volume, it just pushes the nipple out a little bit, and maybe an optical illusion that it's lifted, but not really. And if you take volume away, it doesn't drop to the floor. It just kind of retracts back. And then there's that sometimes an optical illusion, but you know, the upper pole might be a little bit flatter. And so people think that their nipple is lower. But with a breast lift, we are trying to raise the nipple areolar complex and ideally center it on the breast mound. That's where you want it.
You don't want the stargazing nipples, which we have sometimes seen on other Instagram accounts. Your nipples should not be exposed in your bikini or your bra. That's our little tip to you. And the other goal is to get all the breast tissue above the crease if possible. And human tissue stretches, so that's not always 100% possible. We have other little tricks up our sleeve like Galaflex and some supportive things. But yeah, it's the whole nipple position. I see children behind you. I have a dog under me.
I have a dog right behind me as well. She's just chilling.
See, this is why Kat and I hang out, because we have this life.
Right.
Oh, is a lift a reduction? Erin, you always ask good questions. Are you prepped beforehand? So reductions always lift the breast, but you don't always have to make the breast smaller when you do a lift.
Right.
And that's another confusing point.
That's a common question. So a lift is changing the shape of the breast, but a breast reduction is decreasing the size of the breast. But I do get my breast reduction patients are sometimes confused about whether I am going to lift the breast at the same time. And I forget to mention that, but yes, absolutely. Yeah. We would not just reduce their usually large and sagging breasts. We want to reshape them, put them back up on their chest, but go ahead and make them smaller. And how small is dependent a little bit on the patient's request.
Yeah, and this is where I'll hear sometimes from patients that male surgeons tell them, like, no, I'm not going to go that small. I think that's not going to look good. Whereas, you know, there's a limit to how much tissue you can remove, but you really can get people down to a B cup with some effort.
Yes. Yeah. And I have recently found myself doing that more and more often for women who are like, yeah, I am over these, and they call it, they want to be part of the itty bitty
titty committee.
Yeah, titty committee. Yes, that's their request. And as long as I can safely do it, then I am happy to do that, because nobody wants to get like halfway to their goal size and then be still too large. But yeah, so the safety part of that, though, obviously, is making sure that the nipple areolar complex, which is important, stays alive during that procedure. And so that is one of the risks of a breast lift or a breast reduction, is making sure the blood supply to that nipple stays alive so you keep your nipple, which, you know, is, some people assume that's going to happen, but those are definitely, that's something we factor in when we're doing the surgery and try to keep as safe as possible. It's a reason why I won't operate on people who are actively smoking for a breast.
That's what I was just going to bring up. I will do an augmentation, but I will not generally. I'll do an occasional very small lift, but you know, that risk to the blood supply is increased with smoking. So, as Kat mentioned previously, when you do see breasts, and people ask, like, well, if I get a big enough implant, will that lift it? It really won't. The only time that it does seem to work is if women are a little bit deflated and they've lost volume, so there's just more skin than breast tissue, and it's not a true ptosis. It's usually like 1 or 2 centimeters of breast tissue below the crease, and then you fill that back out and it looks pretty good without a lift. But if there's truly a few centimeters of tissue hanging below the crease, you got to lift it even with an implant.
Correct. Yeah. And there are women, though, back in the day, I believe people would convince women to put in 500 and 600 cc implants in an effort to avoid the lift. And it didn't work. You don't get much of a lift. And because you have a bigger, heavier implant, and we live on a planet with gravity, things tend to fall faster. Yeah. So I'm like, well, that'll work if you move to the moon, but until that's colonized right now, I would factor that in. Just like women with larger breasts, their breasts tend to sag faster because of the weight of their breasts. So yeah, you want to offload that weight if possible, and a bigger implant is not your answer, unless those are your goals, but you have to accept that. as
They
a
are. And
issue.
what happens if you do those implants and not a lift, especially, you know, you end up with an implant either sagging down or the implant's up where it should be, where the breast should be, and then you get a waterfall deformity of breast tissue hanging off the breast, and that's not a cool look.
Right, right. So yeah, and so then speaking of whether or not you need a lift, for people who are having enhancement, so adding volume with an implant or fat transfer, I do go over the position of their nipple and give, some people are okay with a natural look as long as their nipple is, you know, somewhere in the middle of their breast and we enhance that, that'll be fine. But if you start talking to me about kind of these, you know, goals of everything kind of stuck on your chest, well, then we can't put the implant there without moving the nipple to that position. And so if that's the case, then yes, absolutely, we might need to have a lift. And that is, it's a trade-off, right? Because what is the downside of a lift? It's incisions.
It's the scars. Yeah, you have a scar around the nipple and down the front, and they're pink for like a good year, and it can be a little frustrating. But once they fade really well in the vast majority of people. Like surprisingly.
Yes, because we see patients who have had breast surgery 10 or 15 years ago, and when they come in, you can't even see the incisions. So much so that I feel like I have a lot of patients who come in requesting maybe a tummy tuck or liposuction, and on their surgical history, they might mention, you know, their appendix was removed or something. And then you're like, the breast surgery? Like we won't notice. Like, I know it's really well faded and most people won't notice, but we're usually capable to notice.
You know, I think sometimes they forget too. They're like, oh yeah, that was 20 years ago.
That's right. That was a surgery. Yes, that counts. So.
And you know, when you see pictures online, most of the pictures are 3 and 6 months out because, you know, as much as I love to see long-term results, I'm not going to drag people back. I'm always happy to see them, but I'm not going to drag them back just so I can get photos. So a lot of those photos that you see online are 3 and 6 months out when the scars are still very pink. You go to a year or 18 months and the scars are much less noticeable.
Exactly. And we explain that a lot in our office too, because oh my gosh, the incisions, but it is, people don't come back 2 years after surgery to be like, oh, hey, I feel great, take my photos. I wouldn't want to
come back for other stuff, and then we're like, hey, while you're here.
Yeah, we're going to need you to take your top off and take some photos. But I'm here for Botox. Yeah, but, so yes, I agree. Totally.
Yeah, so that's usually the biggest concern. The second concern I hear a lot about is changes in sensation, especially nipple sensation, and women do worry about that.
Right. And there is a risk that when you start rearranging skin and tissues that you could have decreased sensation or no sensation afterwards. I would say the no sensation is pretty rare, but it's a possibility. And the decreased sensations is almost a guarantee. I have a small percentage of people who wake up with extra sensitive nipples, which I can't figure out, but most people wake up a little bit numb and then things start to come back over the next several weeks to 3 to 6 months. It can take, just depends on the patient. And I tell them that.
My clock is chiming. It hasn't chimed in like 3 months. So. It's just random times. But yeah, it can take a long time. Although I find a lot of women, especially, you know, women who have had kids, sensation's not as much of a concern by that point because pregnancy and breastfeeding and things stretch and sensation changes anyway. So most women are pretty okay with that as long as they know to expect it.
Right. And I do tell them as things come back, you get sometimes sharp shooting pains, little lightning, that's normal. And sometimes itching. Those are the two sensations that come back first for whatever reason. That's how your nerve endings find their way back to their original locations. And they do that by making those annoying sensations first. So,
yep. Yeah. But then get back to normal.
Right.
The next thing I love about breast lift and reduction is that it's not as painful as people expect it to be. Like they think it's going to be this really painful surgery, and there's just not that much sensory nerve in breast tissue. And I've had patients do just Motrin and ibuprofen. Now I do nerve blocks post-op. I don't know if you do that at all.
No, I do infiltrate with local anesthetic at the time of the procedure. But yeah, when you say nerve block, what do you mean? So on all of my breast cases, I do a PEX 2 block, which is ultrasound guided. And I'm basically injecting a mixture of, I use either ropivacaine or bupivacaine with lidocaine and some Decadron. Basically
basically, oh, hi, there's my kid's orthodontist. Hi. So it's a mixture of local anesthetic, some steroids to make it last longer, and some epinephrine to make it last longer. I infiltrate right above the fourth rib. So you get the intercostal nerves that go to the nipple and most of the breast. And then I get between the pec major and minor too, which for augmentations, it gets the pectoralis nerve, which is very nice. It takes like 10 minutes, and we've got a ton of ultrasound machines available at our surgery center. So it's nice I do those before I start all my breast cases.
Oh, so at the beginning of the case. We did have somebody that used to do that when I was in the Navy, a regional anesthetic guy, and he would come in and do that at the start of our cases, and was awesome. But where I am now, we don't have ultrasounds or anybody interested in doing it. But I do it. Sometimes I direct, when I'm intraoperatively, I'll direct the local anesthesia because I know
where you can feel that
is. Yeah. Well, the rib for sure, but between pec major and pec minor, yeah.
You can see. Yeah, it's nice. I used to do intercostal blocks a lot, which basically you have to feel the ribs. And with the ultrasound, I can do them, with a little more subcutaneous tissue laterally. So that's been nice. There's a really good video on Stanford YouTube channel, like their anesthesiology department did it. So I mean, I find that helps, but even without it, patients do very, very well.
Right, because you're not really manipulating the muscles, so.
Right. So I mean, things are sore, but it's not like a tummy tuck where you sit up and your muscle hurts. It's just kind of sore.
Yeah, that's awesome. So the other big category of patients that talk about lifts are ones that are having their implants out, and so we can segue into breast implant removal, which we've talked about before.
Yeah.
But trying to decide if you're going to have implants, if you're going to have your implants removed and not replaced, what's your decision point? Like, everyone wants to know what they're going to look like afterwards. And
it's so hard because often it's 10 or 15 years later, you've gained or lost weight. Maybe you've had kids. So your breasts look totally different than they would have 15 years ago, regardless. And with some people, you can tell, either they have a lot of breast tissue. And we pinch is what we do, guys, when we're pinching the breast. We're checking to see how much breast tissue there is. In some people, it's like skin and a little bit of fat and not much. In other people, there's a healthy amount of breast tissue. So it's hard to estimate. The one time we can figure it out with really good accuracy is if you have saline implants, because we can empty them before we take them out. And I love doing that because then I know, I'm like, here's what you look like. Here we go. Here's your before. Or
exactly. Right. So yes, we offer that as well. We'll deflate saline implants. Usually, at least 10 days before surgery, sometimes 2 or 3 weeks before surgery. I have had patients where I deflated the implants and I thought, that looks pretty good. And then they're like, oh my God, I need a lift. So it's good to be on the same page with your patients that way. So we appreciate that.
It is amazing too, though, what a couple weeks can do, or even a month. I saw a patient today. I emptied her implant 6 weeks ago. And at the time she looked kind of shell shocked because it looks very dramatically different right after. And that skin shrinks up quite a lot. And today she's like, they look great. I'm happy. Like everything tightened right up and we're just going to take them out and no lift. So it is nice to have that advantage. If they're silicone implants, we can't empty them. So all we can do is kind of make our best estimate and then explain it to you as best we can.
Right. This is, and I show them some, these are patients that are, everyone thinks my skin is glowing. It's just on fire.
It's very, do you have a good light? Do you have a ring light on? That's it.
I do, but yeah, it really, I have no makeup on because I have the radio frequency microneedling. So I was like, oh, I hope I don't look wrecked for this. But I'm telling you that face mask helps cool everything down. So I was going to say, if you have silicone implants, you could also opt to take them out, and the sun is going back and forth.
Your sun, it's dark here.
Yeah, because it's 5:30. You could take them out under local, and then go ahead and see what it's like. I haven't really had anybody opt for that option, but it's an option. Most people are like, no, I'll make my decision. I do have people who decide to take them out and then know that they might need a lift or might need a fat transfer, but they're not done having kids and so are okay with doing removal, and then, you know, knowing that they might not be perfect, but do you really want to have a breast lift or fat transfer and then, you know, have 2 or 3 more kids and then have to start all over again? So that I think is reasonable if you're planning to have kids in the short term. Because you're going to end up stretching things out. And then I tell them, listen, if you're going to have those implants out, don't panic, just like you mentioned with the saline deflation, because even after the removal, the skin, it's almost like the implant's putting pressure on the breast tissue. And so when you remove that out, the breast tissue fluffs up a little bit, and then the skin retracts a little bit. And so you just have to be patient. If that's the pathway you go down with implant removal only, you will have 3 to 6 months of remodeling and your results will get better over time. So don't immediately wish you had done something else. It's okay.
Exactly. Yeah. And that's one of the hardest things about having surgery is waiting, because the final result is not there until a good 6 months out.
Right. Being patient is hard. Yes. So what else about lift? And so one of the other factors I like to talk about with breast implant removal and lift is some of it has to do with the implant to breast tissue ratio, which I think that's our pinch test, right?
Yeah.
So,
if you have small implants and small breasts, okay. If you have very large implants and small breasts, it's a really dramatic change.
Right. And your skin's been stretched out and it's only going to retract so much, you know, you can get away with a little bit. Or if I have older ladies that had implants put in the 70s, and now they're finally getting around to taking them out, and they're completely different people than they were, you know, 40 years ago, almost 50 years ago. And, you know,
they have a lot more breast tissue often.
Yeah. They're like already buxom, and you can take the implant out and you don't even notice that anything was removed. So it just really, it is so individual to the patient and what their goals are. It's, something you have to consider.
But like going back to that question of, do I want an implant or do I want to lift? Because that's often a core question. Do you want your breast or do you want them higher up? They're 2 different things. And you can want both, in which case you'll need an implant and a lift, because an implant's not going to lift things.
Right. So I try to separate it out, but they do go hand in hand with volume and shape. And so an augmentation is only going to increase your volume, and it doesn't really change the shape of your breast. It might fill out the upper pole, but it's basically augmenting any asymmetry you have, whatever the shape of your breast is, it's that shape but bigger. And then a lift is going to address to some degree the shape and the position of the nipple. So. Right.
And really, another thing we can't change really is the footprint of your breast, which is where your breast is on your chest, with some rare exceptions. You know, there's the inframammary crease, and then if you lift your breast up, you can see the crease on top, and that's the natural top of your breast. Adding an implant will raise that, but you know, your breast is where it is, and we put an implant under it, and we want to center the breast on the implant. We can't move the whole breast around the chest. Right.
That's a common question I get for patients that want to know what the increase in cleavage will be with like an augmentation, for example. I'm not really changing where your breasts sit on your chest. So if they're widely spaced, and I always use myself as an example, like I have a whole zip code in between each breast. That's just the way they are. And then Erin, her breasts, lovely cleavage come together. That's just the way they are. So some people, the breasts kind of join in the middle, and some people don't, and you can see their sternum, and that's just the look you're going to get. And that isn't going to change. And we can't violate that space. It just ends up making things look super weird if you do.
Yeah, that's where you end up with like the connected implants in the middle. Yeah. So, I mean, those are kind of the limits of what we can do. That said, we can do a lot, but those are the things that we can't change.
Correct. Yeah, I agree with that. And then also, you don't want to move the implant, for example, too far underneath. You need to center it under the breast. Otherwise, the nipples will swing in the opposite direction. So if you move them too centrally, the nipples will go laterally. And if you move them too laterally, they'll end up medially. So those are all things to consider. But we like to talk about that, right, at consultation, because nobody notices any of that until after they have surgery. And then
Who
who
has
has implants and who doesn't IG post. Fess up.
pictures, Erin, and we will be like, yes, yes, no, can't tell. Sometimes you can't, sometimes you cannot tell. One of my
That's true.
patients, in fact, was telling me she had an AUG, and she's like, one of my friends asked to see him, and she's like, well, I can't even tell. They look natural. I'm like, well, what kind of doctor does she think I am? If you come in looking for natural, that's what we'll give you.
Right, right. Yeah. If you don't want to have everybody know you have implants, that can be achieved. And if you want everyone to know, that can often be achieved as well.
Yep.
We need your goals. And then is that like a celebrity conversation, Erin? I wonder, like, are we, because that's like when you pick open those trash magazines, they're always like, what did she have done? So-and-so who didn't treat who's not a treating physician.
People commenting, they're like, well, I don't know them, but I haven't treated them. But here's what I would guess, which is totally fun. But often, like, pictures are photoshopped in such weird ways you can't even tell.
Right. Yeah. It's a best guess at your best. Yeah, I can't. So,
what other questions do people have about Lyft? Probably cost. People often ask about cost, and I'm in Cleveland, so cost is probably going to be a lot less than San Diego. I would say we're somewhere around probably like $5,000 to $6,000, including OR and anesthesia.
Oh yeah, so I was like, wow, we're on the same page. But
yeah, no, that's probably surgeon's fee out there, huh?
Yes. Mm-hmm. Yeah, the cost of living's a lot higher around here.
Yeah.
So I would say, yeah, surgeon's fees are five to 6,000, and then OR and anesthesia on top of that. And then if you go north to Beverly Hills, you can just add another 10,000. But
because Cleveland is actually a great place to come for plastic surgery, people, if you didn't realize that. There's a lot of plastic surgeons in Cleveland, and things are not crazy expensive.
Yeah, I think we've had this conversation before because I've compared prices with someone in Nashville as well. We have friends that practice there, and it's a different, it's just a different price point.
Well, and like our OR and anesthesia fees are so much less.
That's true.
Yeah. It's being in the Midwest, but the downside is you live in Cleveland, so the trade-offs. We don't have your beautiful weather.
Yeah, we do definitely pay a sunshine tax here for sure.
Yeah. So then activity-wise, too, people always want to know about time off work. I mean, I tell people a week for most things, unless they're getting multiple procedures. But I've had people go back a little bit sooner if they wanted to, or if they were, popping in on Zoom. Right. But I always have people wait a full month before getting back to, like, spinning, running, weightlifting kind of things. Are your restrictions pretty similar?
Yes. I usually tell people 2 weeks without raising their blood pressure or heart rate, so don't do anything too dramatic. Yeah. And then I also tell them 4 weeks before you do any kind of intense activity because we just we want everything to heal properly. But yeah, as long as you're not taking heavy narcotic pain medications, you can go back to work as long as your job isn't, pushing heavy things around. So, and a lot of people are having surgery now because they can work remotely from home, and then
it's easy to take that time off and then just pop in for your Zoom meeting and then go to
Right. Yes, that is true. What should we, our half hour is almost up. Should we?
So fast. What do you guys want to hear about next time? We've covered lipo. We've talked, have we talked about tummy tuck?
We have not. I think that's a good option if nobody else has any suggestions. I think we could definitely talk about tummy tuck.
Yeah. Really, we talk about all my favorite stuff because I like to talk about. All right, well, tummy tuck will be good. I think it's my turn to host. I'm going to put it in my calendar so I'm not scrambling through text messages at 8:30 going,
That's my carpool. Like, who's got ballet today? Wait, what? I agreed to this plan on Monday, and
I'm not even ready for that. My oldest is in first grade, and I don't know if I'm going to try to convince my nanny to be like our household manager at that point and just, Brazilian butt lift. That is a good one and fraught with interesting conversation topics. We could do that next time and save time. Sure.
Yeah, absolutely. Yeah, I have had a couple in the last couple weeks, and I have one coming up, and it's an operation that I didn't think would be as popular as it became, nor
Yeah.
one that I thought I would be doing that often. But
And it's got some interesting little anatomical quirks too, and especially talking about long-term results. And it's a little bit different than fat grafting other places like the face or the breast. So we can talk about how that's different as well.
yeah.
All right, Amy, you picked it.
Good job.
What do you want to do? 2 weeks?
Yes, we'll do it in 2 weeks, whatever date that is. But we can text it.
If there's something else on there, I'll text you.
Okay.
But we'll be sure to put posts on our Facebook, Twitter, Instagram, reminding you guys to chime in. And then we always do save the recordings and post them on our IGTV too. So.
Yep. All right, everybody. Thanks for joining us.
Yes, it was lovely having you. And if you have topics that you want to hear about in the future, just shoot one of us a DM.
Yep.
All right.
Bye, everybody.
Bye.
Bye.